and I'm continuing on with our theme of post-dural puncture headache in this meeting, which has been extensive. So what we're talking about now is the woman who your colleague wet tapped, who has had a successful blood patch, gone home, and is now calling you from her house saying, it's back, what do I do? So what we're going to talk about is some things you can do to optimize how she feels. I'm not going to talk too much about how to use some of the things like spinal catheters. We've gone through a lot of these topics beforehand, but ways you can make her feel better, looking at whether the patch was done optimally the first time, and then perhaps most importantly, go through some of the differential about what if this isn't a post-dural puncture headache, what else could it be? So why does it matter? It matters in part because we get sued for this. These are the top 5 causes of lawsuits in obstetric anesthesia back in the 70s and again when it was revisited in 2009. And guess what? It remains our number 2 cause of getting sued by obstetric patients, mainly because it wasn't handled well. If you read the depositions from these women and you ask the obvious question is, really, you're suing somebody for a headache? What they say is they ignored me, they didn't do anything to help me, and they were angry at us. So part of this is just how do we make her feel better while we figure out what to do or get her to agree to a second blood patch if that's what we think we would need to do. So first of all, is there some adjunct therapy we can use to help while we're either going to do another blood patch or not? And then look at how the blood patch was done the first time. Was it done too early and therefore there's a good reason it might have failed? Did they not get enough volume into that patch so it might have failed? And finally, is that diagnosis wrong? What's in the differential? So what are some adjunct therapies we can try to help her feel better as we're talking to her on the phone and deciding what to do next? Well, first off, make sure she's got pain medicines, and I mean real pain medicines, oxycodone kind of pain medicines. This is not a minor headache. This is a debilitating, can't stand up headache. Just using NSAIDs and Tylenol is not going to cut it. Some patients benefit from a muscle relaxant, something like Flexeril, because you know how it is, you have a bad headache, you start walking around like this, and the next thing you know, you have a lot of cervical myofascial pain that's going along with it. Caffeine, we'll talk about in a second, may provide at least some transient symptomatic relief, and people have also looked at Theodore as a longer acting version of that. The triptans that we use for migraines, especially if she has a history of migraines, may be something to try. ACTH or Cosentropin we'll talk about, and eventually you probably are going to have to repeat her blood patch if that's what it is. Now, anesthesiologists really vary widely. We're back to our herding cats metaphor again, but we vary really widely on how we handle wet taps and how we handle the patient with a post-dural puncture headache. And one of the things that's remarkable is how much we use ineffective therapies, things that have never been shown to work. Let's start with hydration. There's nothing about hydration that helps a post-dural puncture headache. The body does not make more CSF because you hydrate the patient. What it does is makes her need to pee. And guess what? Every time she has to pee, she's got to stand up and walk to the bathroom. Her headache comes back full force and she hates you. So I'm saying, yeah, have her drink to comfort, have her drink things that have caffeine in them, but there's no reason to focus on this issue of hydration. Bed rest is ridiculous to tell a new mom to stay in bed. She's got way more things to do than that. And again, abdominal binders, having her not push, the caffeine thing we'll talk about. Probably not helpful. The things that we do know are successful, that we have at least some pretty good evidence for, we're not using often enough. And that would be things like Cosentropin, like neuraxial morphine, and like intrathecal catheters, and certainly blood patches. So let's talk about those, because after all, as it says here, doctors can't make you immortal, but with good luck, they can prolong your suffering indefinitely. And again, we get sued by people because we're prolonging their suffering indefinitely. Okay, so the adjunct therapies, again, the things that aren't useful, don't tell a new mother to stay in bed. That's ridiculous. Hydration, orally or IV, is not doing anything for the headache. Abdominal binders, trying to do your blood patch immediately after she delivers has not been shown to be a successful strategy. NSAIDs, we focus a lot on those, and they are not helpful. And likewise, epidural saline patches or putting other things besides blood in the space, not good evidence for any of those, and potentially dangerous even if they could have some neurotoxic type of effects. So what are we going to focus on to try to make her feel better? Well, this is an animal study where they measured cerebral blood flow in pigs using a Doppler technology. They went around and removed CSF in the way that a wet tap would make the patient lose CSF, found that cerebral blood flow increased. Thus, at least one part of why she has a headache. When they did the blood patch and put fluid back in that space and ICP went up, cerebral blood flow went back to normal. So that at least indicates that in part post-oral puncture headaches or vasodilation headaches, and therefore vasoconstrictors might help. And that's where the caffeine idea comes from. And indeed, we do have some evidence that at least transiently you can make them feel better. Certainly the migraine preparations you buy over the counter in the drugstore, they all have caffeine in them. And that's part of the therapy of what they're doing. As I said before, Theodore is kind of a long-acting way of trying to continue that cerebral vasoconstriction. Now, caffeine's unpleasant for a mother. She's already not sleeping well. She's sleeping at irregular hours. She doesn't feel good, and to give her something that's going to keep her awake and make her jittery is not a great thing. But you can at least tell her whatever she's drinking should have caffeine in it, and that might make her feel better. Triptans, again, migraine therapy, there's a gazillion of them out there. Imitrex is often the generic one that's on formulary, and it's cheap. So 50 milligrams PO, see if it helps, again, especially if she's had migraine headaches in the past. Now, some other adjunct therapies that might not seem completely intuitive are ACTH and cosentropin. So just anecdotally, you'll find these case series in the literature where they gave ACTH, you can see the dose here, and reported really high effectiveness. Why the heck this would work, who knows? But it's pretty innocuous. Really, the only side effect would be having an increased glucose. So rather than treating it, this study looked at whether you could give ACTH prophylactically. So you know you've got the wet tap, she doesn't have a headache yet, can we keep her from getting a headache? So they randomized women who'd had a known wet tap to either get a saline bolus at the time of delivery or cosentropin IV. Cosentropin is just a synthetic form of ACTH. And they found that indeed the post-oral puncture headache rate was much lower in the group that got cosentropin, 69% to 33%, and the need for blood patch was much lower also. Not an expensive drug particularly, no real side effects, easy to call your pharmacy at the time you're writing your nursing orders at the beginning of the case. They can have it there by the time she delivers. You push it IV and cross your fingers and stand on one foot and hope for the best she's not going to get a headache. Now, another one that, again, is kind of counterintuitive, why in the world does this work, who knows, is neuraxial morphine. So again, just some case series out there in the literature where anecdotally they try giving epidural morphine to patients and found they had good relief of pain pretty quickly. Not necessarily a practical thing for us to do unless you already have the catheter in and you have some reason to keep her in the hospital for 24 hours. But this was a study where they were randomized to get 2 epidural injections 24 hours apart. One group got morphine or saline first. Then they flipped, got morphine or saline the second times, and the post-oral puncture headache rates, again, in the morphine group were much, much lower, and the need for blood patch was 0 in the morphine group, 25% in the saline group. So not great studies, almost kind of anecdotal evidence, but again, if you have an epidural catheter in, maybe she's had a C-section or she's finished laboring and she's going to be in the hospital for a couple days anyway, probably worth trying. Now, so you tried to make her comfortable with some other things to do here. Now you're going to look back at the blood patch as it was done and say, well, is there a reason it failed? Maybe this just wasn't an optimal blood patch. So one thing to look at is timing. We think that it's probably better to wait at least 24 hours after delivery before we do our first blood patch. And the reason for that is mostly retrospective. This was actually a prospective, but just observational study of 500 patients who got an epidural blood patch. Overall failure was 7%, but the things that increased the failure rate was when the needle was bigger, so a 17 versus an 18 gauge 2E, and if the epidural blood patch was done within the first 3 days. So this was a database review, again retrospective, not a randomized controlled trial in any way, but the overall success rate of the first epidural blood patch was 89%, which is pretty typical. But if it was done more than 48 hours after delivery, 86% were completely cured by that first blood patch. If it was done 24 to 48 hours, went down to 65%. If it was done within that first day, the success rate was only 50%. So something to think about. If you can buy yourself time to get out a few more days, that's probably good. So if this woman's blood patch was done in the first 24 hours, you could say, okay, well, that's a good reason it failed. Reasonable to do another one. Another thing to look at is how much volume did you get into your blood patch? Was that optimized? And again, we don't have a lot of good studies. This is probably the best one that's out there that was mentioned before. They took 120 women, randomized them to get either 15, 20, or 30 cc's in their blood patch. Now, one of the things to realize is that a lot of these women didn't get their allocated amount, because we've all done blood patches, right? You mean to get in 20, but at 10, she starts saying, stop, 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 it hurts, and you have to quit before you get in all you want. So only about half of the 30 ml group actually got 30 mLs because they couldn't get the volume in. But they found that the permanent relief they got was probably maximized at about 20 mLs. There was no reason to go higher than that anyway. The improvement in headache wasn't really any better. Now, one of the things, again, we think is the cause of the headache is this cerebral hypotension. So this was an interesting way to look at it. They were using ultrasound to measure this optic nerve sheath diameter and found that a successful blood patch that made the headache go away increased this optic nerve sheath diameter. And they're using it as a surrogate for ICP, and I'll show you a picture in a minute. If the epidural blood patch failed, it didn't show any signs of increasing ICP. So I'll see if I can point at this over here, but I'm not doing this, by the way, so I'm trying to explain this technology, not from personal experience. But you can see here, this is before the blood patch, and you can see about how wide it is, and after the blood patch that was successful, so the headache went away, it got bigger. So again, evidence that increased ICP is what we need to do, meaning we need enough volume in the epidural space to really push on that and raise the ICP for us. Now, having said that, you can go overboard with this whole volume thing. So these were two parturients who got complications after really large blood patches. So the first one got a single injection of 58 cc's of blood. Can you imagine? And actually developed a subdural hematoma, maybe from tracking as much as anything else. Second patient got 3 blood patches over 4 days because they kept failing, total of 165 mLs of blood in the space. And developed arachnoiditis. So you can, again, go overboard. There's no reason to go past that 20 mLs. We don't have any evidence that more than that's any better. So you've done all those things, and you're still thinking to yourself, I don't know, should I do another blood patch or not? And this is when you need to start thinking about, what's the differential here? Am I missing something important, something that could really harm this patient and be damaging to her? So again, this is the International Headache Society definition. Within 7 days, goes away in 14, worse when you're upright. We know all this stuff. We know what these headaches look like. Well, how common is a postpartum headache? Okay, not a post-dural puncture headache, but how many women after they've had a baby get headaches? A bunch of them. So 39%, and that's pretty typical across other surveys. Most of these are going to be primary headache disorders, things like tension headaches, migraine headaches. Caffeine withdrawal is a big one, so that's another reason why caffeine therapy may help her feel better. Risk factors in this study for developing a headache, though, were top of the list, and inadvertent dural puncture, and then previous headache history. So that's an important thing to be asking the patient. Have you had headaches in the past of any variety? And this is where the blame game comes from. Okay, we're all anesthesiologists, right? How many times do you get called for a headache only to find the patient never even had any kind of interaxial anesthetic? We've all had that experience, right? So headaches got to be anesthesia related. I don't know if you can read this, but the doctor's saying fixing your ingrown toenail might hurt a little bit, and it seems we're all out of Novocaine, so we'll do like they did in the olden days here, bite this bullet. You see the big kapow. Now he's out talking to the grieving widow saying, well, unfortunately, your late husband had a severe allergic reaction to the anesthesia. We're kind of an easy scapegoat because what we do is so mysterious, people don't know what to think about us anyway. Okay, so again, this is another survey of over 5 years, what kind of postpartum headaches are being seen. These are recommendations for obstetricians on how they should manage a postpartum headache. So first of all, they reiterate tension, migraine, headaches, that's the most common diagnosis. Late onset preeclampsia is also another big one that you want to rule out, and that accounts for us too. You should at least be getting a blood pressure to rule out preeclampsia before you do any blood patch. Cerebral imaging is indicated if there are neurologic deficits there or if they're not getting better even though you've treated the presumed diagnosis, and that might be a failed epidural blood patch. And they go on to say that consultation with an anesthesiologist should be done if there was a regional anesthetic involved, or with a neurologist if you have neurodeficits. You can get scanning. I think this is an important thing that we don't always realize, which is the amount of CSF has nothing to do with the headache. So there have been a number of studies that have labeled CSF in the space and then scanned patients, and you can have gigantic volumes of CSF in the space and the patient has no headache symptoms at all, or you can have teeny tiny 2 ml amounts and the patient has a raging headache that she can't get out of bed with. So that's actually not a particular determinant of who it is that's going to get a headache. Likewise, not every wet tap causes a headache, and even after a wet tap, she can have a headache for a completely different reason, thus the differential. So what are we considering in our differential diagnosis of this headache? She could have a migraine. Does she have a history of that? We can treat that pretty easily. She could have this cervical myofascial pain either because of her headache or because she pushed for 14 hours and all those muscles are just sore as can be. She could have a pneumocephalus, especially if our epidural is done with loss of resistance to air. She could be infected, and that's a big one we don't want to miss. Talked about caffeine withdrawal, cortical vein thrombosis we'll talk about in a minute, a hemorrhage, or preeclampsia, eclampsia. So let's talk about some differential and some cases that have been mistaken for post-dural puncture headaches. Starting off with the thrombosis cases. So this healthy gravida 1, active labor, gets a wet tap when her epidural is placed, postural headache, blood patch, goes home. Usual scenario. But day 3, postural headache recurs. She comes in from home, gets a successful blood patch again, goes back home again. Headache now recurs on day 5, 2 days after the second blood patch, but now it's not really so postural, so she gets seen by the neurologist, says, oh, well, this is clearly a migraine, and treats her for that. Next day, she appears in the emergency room, has 4 witnessed grand mal seizures, is not waking up from her postictal state. Finally, they take her to MRI, and she indeed has a cortical vein thrombosis, which is usually correlated either with patients with a known thrombophilia, those with preeclampsia, or those who are really dehydrated for some reason. Another case report, 27-year-old, wet tap, gets a headache within 12 hours of delivery, but starts having seizures at roughly the same time. On further exam, including an MRI and a CT, she has a partial thrombosis of a transverse venous sinus. So while they're working that up to find she has a protein C deficiency and a factor V Leiden mutation, they heparinize her. She does completely recover by 7 months out, good health. And you can see here, this is an MRV, and you can see here the thrombosis in the lateral sinus in both of these views. And finally, this patient had a wet tap during her epidural, got an intrathecal catheter placement. They pulled out the TUI from the first wet tap, placed it in another interspace, but could still withdraw CSF from the spinal catheter now. So she does get a headache the next day, failed conservative treatment for 24 hours. They were trying to wait, and then had a blood patch. They only got 10 cc's in, but she had good relief, went home. 10 days after delivery, so 7 days after her blood patch, she presents with a worsening headache, now has neurologic signs, a workup again. She has a cerebral thrombosis and a deep ganglion infarct, but did recover after heparin therapy. So again, remember, parturients are thrombophilic. They want to clot. So blood patch and new symptoms or slightly different symptoms should make you think about some other thrombotic problem. This is a great review of thrombosis, intracerebral thrombosis in the parturient, and they bring up 4 good points after a good review of the literature. One is that you need to think about this in your differential of a postpartum headache, especially if she is known to be thrombophilic, and really, again, that is all parturients. These cases may present with a postural headache that looks just like a post-dural puncture headache, but the headache often changes over time. It was positional, now not so much. They didn't have vomiting, and now they do, things like that. You do an epidural blood patch, you don't get the relief you expect. And finally, that you should think about at least a brief neurological exam. Can they move anything? Do they perceive any differences? And if you see that, then you should get some kind of imaging before you proceed. Okay, what if they bleed? What does a subarachnoid hemorrhage look like in this setting? This was from the nationwide inpatient sample that we've seen a number of examples of during this meeting. Found the incidence is about 6 per 100,000, so not a common thing certainly, but 67% of them postpartum. And I had a personal experience with this as well. Got called to see a woman who'd had an epidural for a labor and then a C-section because she'd developed a headache. Walk in the room, said, "Tell me about the headache you're having." And she said, "Well, you know, I felt fine. I was up at the sink, I was brushing my teeth, and all of a sudden, bam, worst headache of my life. I had to go lay down in bed." And I'm like, well, that's not exactly what I was expecting. And sure enough, took her to CT, and she had had a subarachnoid hemorrhage. Demographics here were older mothers, African-American race, higher rates of hypertensive disorders, etc. But again, something to think about. This woman had a intracerebral hematoma, unintentional dural puncture, got a general anesthetic for cesarean because they needed to move on, didn't have time to try to place another block. And then she got routine thromboprophylaxis with low-dose heparin after her C-section. Next day, complained of a severe headache, didn't respond to fluids or caffeine, no surprise. They did do a blood patch. It was completely uneventful, but 1 or 2 hours later, she developed hemiparesis, and on CT scan had an intracerebral hematoma. So again, all of these perfectly reasonable scenarios that you could very easily walk into and say, "Oh yeah, sure, I know what this is. I'll treat it with a blood patch." Turned out to be something else. Very unusual diagnosis here. This press is, let me see if I can get this right, posterior reversible encephalopathy syndrome. So this woman had an uneventful spinal for a C-section. 2 days later, severe postural headache. They were kind of like, gosh, it was only a spinal. Why did she have a headache? So they treated her with conservative therapy for probably way too long, 10 days. Still had a 10 out of 10 headache. Now it's no longer postural though, and she's becoming more somnolent and confused, was having some visual hallucinations. So they took her to CT, which was normal, and then they did an MRV, which was normal, and then finally they did an MRA to look at her arterial system, and she had this diffuse vasospasm. They treated it with magnesium, interestingly, which is what we think we're doing with magnesium therapy for preeclampsia, and you can see that on the left you have the pre-magnesium and how skinny all these vessels are. Post-magnesium, she looks like this and went on to recover. Subdural hematoma, I think, is probably the most frequent one that we see as a substitute for a headache versus a post-dural puncture headache. Here again, similar scenario, inadvertent dural puncture, positional headache. Blood patch didn't really give her good relief though. It gradually became non-positional, was associated with pain and paresthesias in her lower extremities, so because she had neurologic deficits, she goes to the CT scanner and has a bilateral subdural hematoma. They were able to manage this, interestingly, conservative. She didn't have to go to the operating room, but you can see the arrows here. Again, how she has bilateral subdural hematomas, and she recovered and did well with just conservative therapy. As opposed to this woman who did not, she had an elective repeat C-section, spinal, severe headache, and vomiting 4 hours later. She was also having some tachypnea and complaining that she was having trouble breathing, so they decided to treat her for a pulmonary embolus and started her on therapeutic Lovenox. So mental status changes kind of got worse, and they took her to CT, and she had a big subdural hematoma with a midline shift. So they had to go to the OR, fresh on a full dose of Lovenox, and things did not go well. She bled excessively, had to be packed. Eventually, after a long, complicated course, did get better. But before you start them on their anticoagulation, think about imaging their head. Meningitis, gosh, we hope we never see this, but just a few years ago, the CDC reported 5 cases of meningitis associated with neuraxial anesthesia. There were 3 cases in New York, 2 in Ohio, each one associated with a single anesthesiologist who was not wearing a mask, and the bug cultured, when they could culture something, was out of the nasopharynx of those 2 anesthesiologists. So, thus the recommendation, you need to wear a mask because you don't want to see this. But Taking a temperature, asking the patients about signs, symptoms of infection is also important before you do a blood patch. And then preeclampsia, of course, we don't want to miss. We've had good lectures on that this week, but most of the time when preeclampsia presents as a delayed, it's associated with headache. So again, patient comes back to the emergency room after her vaginal delivery, has a headache. Who's going to get called to come see that lady? It's going to be us. So checking a blood pressure and thinking in your head, could this be late presenting preeclampsia, is important. 63% in this series didn't even have a diagnosis of preeclampsia while they were in the hospital for their delivery. This was, we don't see eclampsia very much, right? I mean, we're pretty good at preventing that, but this was a hospital in Tanzania that had a fairly high incidence of preeclampsia. They looked at, eclampsia. So these were women who came in with seizures. 20% of them had no symptoms, but when they had symptoms, 80% of them, it was a headache. So again, postpartum eclampsia, headache, who's going to get called down to the ER to see them? So in summary, what are the considerations if you're going to do that second or even third blood patch for what you're pretty darn sure is a post-dural puncture headache? Okay, about 10% of women across the board are going to need a second patch. Our blood patches are not 100% effective, so it is reasonable to do a second one. And the first time you do it, you should counsel the patient that about 90% of people get better, about 10% don't, so it is a possibility of needing a second one. But if that headache comes back, think about your diagnosis and rule out other causes, especially infection and preeclampsia. But a neurologic exam to rule out intracerebral pathology is also very reasonable. So take a blood pressure, take a temperature, do a brief, can you move everything kind of neurologic exam. And then if you find those kind of symptoms, you want neurology and you may want to get imaging. Because epidural blood patches themselves are not innocuous, even if they're done appropriately. This was a multip, active labor, had an epidural placed, wet tap. Actually, she got almost a total spinal. She had a T4 block off of her testos, but she delivered on her testos and then was discharged after a blood patch to relieve her headache. Within a few hours of that blood patch, she got severe radicular pain. Her PCP treated her for an entire year with this radicular pain before referring her to an orthopedist who got an MRI and found she actually had a calcified epidural hematoma where her blood patch had been placed. They did surgery, removed her epidural hematoma, and she got better. And I'm not a great MRI reader at baseline, but it has big arrows on it, so I know where to look. So anyway, this was her calcified hematoma related to her epidural blood patch that was giving her all these horrible symptoms. Some other considerations, if she has cranial nerve palsies, and by that I mean ringing in her ears, loss of hearing, diplopia, those patients need to be moved along pretty quickly to a blood patch because that's a nerve you're stretching and that nerve will become ischemic and she might not recover those symptoms. So those kind of symptoms from the patient need to be moved ahead on. Prior blood patch does not increase her chances of having a failed epidural later, so you can reassure her about that if she's worried. And we do have evidence that if your patient's HIV positive, that those blood patches are okay as well. A lot of times these are diagnostic blood patches that were done in HIV patients to rule out some sort of an infection, but these patients were followed for up to 2 years and there were no sequelae related to the blood patch that they could find. And then last but not least is the billing question. Do you bill when you do a blood patch? Do you bill if you're doing the second blood patch? Or are we treating our own iatrogenic complication and we just ought to do it gratis? This was a nice pro-con discussion in the SOAP newsletter a few years ago. On the yes, we should be billing side are the points that, well, it's a known complication and she consented for it. And patients expect to be charged for our services, so if you don't bill her, she's going to think you did something wrong and you're trying to cover it up. On the no, we shouldn't be billing for our blood patch treatments is the writing off bills reduces litigation, which we know to be true, and actually billing for a blood patch may consider to be double billing because of the CPT code it's under. So that's something your group needs to decide how you want to handle that. So in conclusion, we do get wet taps in labor, even the best of us, and even if it's our colleagues, every institution has wet taps. Some of those may be unavoidable because of the patient's anatomy. You can give good analgesia in the subarachnoid space if you want to convert to a subarachnoid catheter. You need to treat post-dural puncture headaches early and aggressively because these patients litigate. And if nothing else, you want to do a lot of hand-holding and phone calls and warm fuzzies with this patient to let her know that you're concerned about her. And then consider your differential. What might we be missing that could actually be dangerous to this patient that has a much higher priority than a blood patch? And with that, I will close. Thank you very much.